Hello, future nurses. This is Professor Flourish. Today we are going to be talking about Chapter 7, Concepts of Rehabilitation for Chronic and Disabling Health Conditions. So some of the concepts for this chapter are, again, mobility, elimination, and cognition. I can't stress this enough, especially with your older populations. Whenever you're studying, always think about your considerations of mobility. Is my patient safe? Are they at risk for falling? You always want to assess for that first to make sure, do I have them in a safe environment? Elimination. Are they able to have a bowel movement? Are they having too many bowel movements? Watching to see if they can go to the bathroom. Are there medications that are putting them at a higher risk of losing a lot of fluids? Cognition. Can I actually have my patient sign a consent form? Are they cognitively aware of what's going on? Do they need help with their ADLs? So those are the primary or priority concepts that are in this chapter. Like I said, with your older adults, those are the big main three things you always want to ask yourself whenever you're dealing with an older patient. The interrelated concepts in the tissue are tissue integrity, nutrition, sensory perception, and system thinking. So all of these can kind of relate back to that priority concepts. Because if you think about it, tissue integrity, if I have somebody who has decreased cognition, do they know to turn themselves? If they don't know to turn themselves, then what can I do to prevent them from getting a pressure ulcer? And that's how you can kind of think like a nurse, is think about kind of all the situations that can come across with this patient and how you can prevent them from getting worse and how you can help them get better. Oops, sorry. Rehabilitation, philosophy of practice, and an attitude toward caring for those with chronic health conditions. So basically what rehabilitation is you're too healthy to stay in the acute care hospital, but you're not healthy enough to be by yourself. So what we have is this rehab center where for whatever reason, we can go ahead and keep you here. So that way we've got a healthcare provider that can give you care. Health problems can be physiological or psychosocial in nature. So you can have somebody who came in because they had a knee replacement and their house isn't suitable for them, or you can have somebody who's dealing with drug addiction and they need someone to help them get through that process. Care differs for every patient and is often geared towards um, retroactive or adaptive. So basically, the care depends on how much care the individual needs. So it's not just a uniform blanket form of, okay, we're going to do this, this, and this. Because like when you go to clinicals at the hospital, it's very structured of every 2 hours, you're going to do this. Every hour, you're going to do this. You have to get vital signs at this hour, no matter what the patient is. Here in rehab, it's more geared towards what's going on with the patient. I may not have to see them as often, but they may need to see physical therapy more often than if they were at the hospital. So chronic and disabling health conditions, they are very common in our populations. I mean, honestly, a lot of people are dealing with chronic disorders as well as disabling health conditions. They're very, very expensive. To have a chronic illness, for example, something like an autoimmune disorder, a lot of those medications, because we haven't done as much research into the medication, can, with even sometimes with insurance, can cost somebody anywhere from $200 to $300 a month, and that's on the low end. Preventable. So there are things that people can do to help avoid having chronic health conditions, which as you progress through the med-surg courses, you'll see about this preventative care of what we can do when we see, okay, I have a strong history of a stroke in my family. What can I do to help prevent myself from getting that stroke myself? Doing things like testing, diagnostic tests, prophylactic surgeries, anything of that nature in order to help prevent me from having this chronic health condition. Some of your chronic health conditions include things like strokes, um, coronary artery disease, um, COPD, arthritis, all of these things that they don't really have a cure, so we're just kind of dealing with them. COVID-19 has created a new population with intense rehab needs, just because of the nature of COVID-19 and everything that happened with COVID-19. we have a lot of people that got very sick from it and developed other chronic disabling health conditions. And you can also have it result from accidents. You can be a completely healthy individual. Like, let's say you're 24 years old, you get into a motor vehicle accident and you get a traumatic brain injury. Now you are also requiring a long-term care facility. Um, Same thing with your spinal cord injuries. Rehab setting, most people live independently or with assistance. So this is where I say it differs from that acute hospital setting, is that here we want them to get as much independence as we can. A lot of times the goal for rehabilitation, the goal for rehabilitation is to get them back home. So that's why we say we want people to do as much as they can on their own. So you can have inpatient rehab facilities, skilled nursing facilities, long-term care hospitals, and home health agencies. So with this, you can have where they stay there for a long period of time. It can be something like a knee replacement where I'm going to be there for 2 weeks, or it can be something where you have home health, like somebody from an agency coming in to check on the patient. So some of the factors that determine your post-acute care. Biological. What's going on with your patient? What do I need to get done for this patient? Socially, what are some of my social aspects for this patient? Financially, environment, systems. There's all kinds of different factors that can determine what this care is going to be like. If they can't afford the facility, then we have to reevaluate where we're going to place them. Is it safe for them to go home? Do they have a safe home environment? Like I said, you're going to hear me say that word safety a lot because when you're kind of looking at older adults, when you're looking at your patient population, you always look at your assessment data first, and then you start looking at everything safety-wise because you want to make sure your patient is safe. Here are some different rehab care, inpatient rehab, rehabilitation facility, resource intensive, skilled nursing facility, part of the hospital or long-term care setting. People in these facilities are called residents and have all the rights of somebody living at home. So like I said, they don't follow the same strict things that we do at the hospital. They can walk around. It's not you have to do this, you have to do that. It's more just, I kind of live here while I'm trying to get better. We also have this thing called group homes where individuals with disabilities live together. Care providers can help with their ADLs. Patients may or may not be employed. So you can't have group homes where some of the patients actually go to work. This provides independence outside an institution. So it definitely helps to get them back into society. So what is the interprofessional team? Like I said, whenever you're studying, kind of think about who you would call if you don't know what to do next. Or let's say who to call when you're the RN nurse and you basically need someone else to delegate a task to. So you have nursing and nursing assistants, rehabilitation nurse and nurse manager, physicians, um, psychiatrists, physician assistants, advanced practice nurses. So you got a whole array of people. And a lot of these are the ones that we're usually kind of used to that we see in the hospital setting. And a lot of times what you'll see as well is LPNs at a lot of these long-term care facilities. Then you also have physical therapists, occupational therapists, speech and language pathologists, rehabilitation assistants, restorative aides. So sometimes these assistants can be somebody who just has the patient walk around and like helps them do those kinds of things. What I will say is make sure that you know the difference between all of these different types of interprofessional team members. What does a physical therapist do? What is the point of a physical therapist? Gross mobility skills. So this is basically teaching them how to physically walk, transfer, ambulate, toilet. So how are they going to physically go from being in the bed to the bathroom? It's a very important job. And what I will say is whenever you see physical therapy going into a room, if you get the opportunity to watch them because they are very good at showing body mechanics. Occupational therapy. A lot of people end up mixing up occupational with physical therapy. Well, physical therapy is gross mobility skills, so that's their overall mobility skills. Occupational therapists are their fine motor skills. So that's eating, breathing, grooming, and dressing. So this is their ability to actually use a fork or needing assistant devices to do things like eat, bathe, groom, and dress. Now, in the hospital setting, a lot of times you'll see these two come together, the physical therapist and occupational therapy, because it's easier if they've got somebody who has a very difficult time moving. Then you've got your speech language pathologists and assistants. These are people who see, can they talk? Can they swallow? What's their language like? So sometimes it may be that they need a little bit longer with speech therapy. So they can, I guess, graduate out of needing a physical therapist or an occupational therapist, but they still have trouble talking. Then we've got recreational activity therapists, recreational and leisure activities. So a lot of times you can have somebody who kind of develops these like macaroni art or anything that they want to do under that sense. A cognitive therapist or neuropsychologist, cognitive retraining. Social workers identify support sources and resources. So with this, anytime you've got financial problems, a lot of times we'll call them social workers or we'll call them case managers. You want to talk to them about it. Because unfortunately, if it's something like you need a walker at home or your patient needs a walker or they find out that they can't afford their catheter, anything of that nature, we need to go to the person whose job it is to find resources. That's why I said with this interprofessional team, you want to know who does what, because if I go up to my physical therapist and say, hey, they need a walker, they're going to say, yeah, I agree, but they may not be able to do the finance part of it. So this is where you go to this person who can identify that, yes, they need this walker, and we're going to be able to find how to pay for said walker. A clinical psychologist, mental and behavioral health. So we've got people there that can also help with that. Vocational counselors, job placement, training, and education. So a lot of times for these group homes, you may have somebody who had a long history of drug abuse, and it's very hard for them to find a job. If they have a history of a felon, anything like that, or felony, anything like that, it makes it a lot more difficult. So these people are here to help them reestablish themselves into society. How can I go from, yes, I did those things back in my youth, but now I want to be able to um, expand myself. Something that's kind of neat at our institution actually is that they have a whole program dedicated to helping out where some of the professors go to I think it's the prison and actually help them get degrees, which is very helpful because then once they get out of jail, they'll be able to go back into society and hopefully get a job. Spiritual care counselors, dietitians, and then pharmacists. So once again, all of these people work together in order to have the best care possible for these patients. Okay, so the rehabilitation milia or the setting of the rehabilitation center kind of allows time for patients to practice self-management skills. So the whole idea behind it is no matter what the reason is that they are there, we're trying to encourage them to be as independent as we can. Encourages patience and provides emotional support. Um, the thing about it is you have to celebrate the small victories because even if they do something small, like they're able to eat with a fork instead of having to use an assisted fork, that's something that we need to be able to say, hey, you're doing a great job. You also need to be able to therapeutic speak with these patients and understand that not every day is going to be where they're doing super great. Sometimes they go backwards in their plan of care. So it's all about providing them that emotional support. Promote self-esteem, providing emotional support during bowel training for people with spinal cord injury. Yes, so like I said, a lot of times, especially with these spinal cord injuries, you'll have a patient who was perfectly fine 2 months ago. They were a lawyer, they were a doctor, they were completely independent. All of a sudden, they have some sort of spinal cord injury, and now they're fully dependent on you. You have to remember that that's a very difficult thing from going independent to not to completely dependent on someone else. So you want to take that in consideration and just be available emotionally when they have these days that are a little bit more difficult than others. Um, so by allowing them to have the self-management skills, we do make the inpatient unit a little bit more home-like. And that's the goal, is you just want it to be as, like, I guess, as close to their form of normal as you can make it. Like always, it's super important to recognize your cues. Because the thing about it is, just because they're in a rehabilitation center does not mean that we're not still watching them. So you want to kind of look at their history. You want to look at their history of present conditions, current medication, treatment in progress. So you want to know how far along are they in this treatment. Cultural and spiritual practices, once again, this place is going to be as close to home as we can make it. So they have a certain spiritual practice. You want to make sure that you're accommodating that. Home environment, what is their normal home like? Do they have 4 flights of stairs that they're going to have to walk up? A lot of stairs. Do they have 4 flights of stairs that they're going to have to walk up? If so, then we need to get them to that point that they can do that. Support system. Do they live alone? Do they live with 7 other people? What is their home life like? Usual schedule, habits of everyday living. Like I said, you want to get this as close to what their normal is. Functional patterns. If they couldn't use their left arm before the stroke, they're not going to use it after the stroke. So you want to know, what were they like before this disease process? What kind of functional patterns are they going to do to be physically capable to do the next step? And your physical assessment. We're going to go through some key things to look out for with these rehabilitation patients. Oops, sorry. Cardiovascular and respiratory assessment. Assess decrease in cardiac output, fatigue. So once again, you don't want to overexert your patient. Sometimes we get really eager when our patient is more enthusiastic, but you need to remember, what is their actual pattern of fatigue? Like, just because they're having a good day doesn't mean you want to push them to no end. Maximize limited energy resources for patients with fatigue. So, like I said, when they're feeling good, push them a little, but don't push them too much. You want a consistent amount of um, activity. Assess level of activity that can be accomplished without symptoms. This is the huge thing. If all of a sudden, sorry, this is, ooh, it all went, it disappeared on me. Okay, this is a huge thing here. This assess activity that can be accomplished without symptoms. If all of a sudden my patient starts developing irregular respiratory, like all of a sudden they just start dry heaving or they start breathing really, really hard, then I want to assess them. What is going on with them? Is there some sort of underlying disease that's causing this? Maybe they aren't taking deep breaths. Maybe they've got atelectasis, which basically atelectasis is when the alveoli close from laying in bed too much. A lot of times that's what it's caused by. So maybe they didn't go for their walk yesterday, and now all of a sudden they've got atelectasis. They've got irregular breathing patterns because I tried to get them up, and it's very painful for them to push open the alveoli. So you want to assess for that because you want to know what that underlying disease, underlying problem is. Always check for anything that's irregular. If it's something that I'm used to, I'm not as concerned as something that's brand new. You always want to just see what is different from what it was before. Assess oral intake and pattern of eating. Like I said before in chapter 4, make sure that you're looking at your patient's mouths, because if they've got dentures that haven't been cleaned, it can be very, very hard for them to eat. And then they'll just say, oh no, I'll take soft food, or oh no, I don't want this, or oh no, I don't want that. When all we really need to do is fix their dentures. We either need to clean them or make sure they're fit appropriately. Factors that may interfere with oral intake. Are they taking a lot of diuretics at inappropriate times and it makes them pee at night? They don't want to be incontinent, so they just stop drinking. That's a big no-no. You want to make sure your patients are drinking. Height and weight. Are they at a normal BMI? Your hematocrit hemoglobin. So your H&H are those blood tests that I can't stress enough. So when I work as a nurse, I will say the lab tests that I always look at first are my H&H, my creatinine, and my potassium. And some of you might ask, why is that? H&H, I'm looking to see if I have to do a blood transfusion because my patient doesn't have enough blood, which means they're not perfusing enough. My creatinine, I'm trying to have a very quick look of, is my patient an acute kidney injury? My potassium will kill you. We'll talk about that way more next week, but potassium is one of those ones you just watch after because it can have effects on your heart. Looking at your albumin, how much protein do they have on them? Blood glucose levels. One of the things that I'd always do whenever we went to rapids, because I used to be on the rapid response team, very first thing I would always do is check their glucose and ask them, have they had any anticoagulants in the last 24 hours? Those are the big things I'd always do. Weight loss or gain. A lot of weight loss can indicate cancer, or it can indicate that they're losing too much fluid. So you need to watch that as well. And weight gain, are they retaining fluid? Elimination, are they constipated? If they're really, really constipated, what's something that I can do that's the least invasive? Increase their fiber. I want them to have increased fiber so that way it's easier for them to actually have a bowel movement. Now, when you increase fiber, you also have to increase fluid because if you don't, it gives them a really bad GI stomach ache. I kind of jumped on this, but renal and urinary assessment, baseline urinary patterns. You just want to know what they usually pee as. Like if they're consistently putting out a certain amount of urine every single day, then all of a sudden they drop down or they're having more. You want to assess for that. Nocturia. Are they peeing a lot at night? If they're peeing a lot at night, look at their medications. Is there some sort of medication that's causing them to pee more at night? Fluid intakes, patterns, and volume. You want your ins to match your outs. You want those to be connected. Now, we don't always have them connected, but the goal is that we want, if I give you 400 mLs, then I want you to put out 400 mLs. Urinary incontinence or retention. So watch out for your incontinent patients. I said this in chapter 4 as well. I'm always checking my patients. I do not like them sitting in their own stool or sitting in their own urine. It's a big pet peeve of mine. So if you ever have me in clinical, even if you don't have anybody else to change your patient with, come grab me and we'll change your patient. I really don't like them having to sit in that because I don't think it's fair to them. Retention, keeping an eye on how much urine output your patient has had. If they haven't gone for the entire 12 hours, then get a bladder scanner, check your patient, because it's important that they're not holding on to it. Monitor for UTIs. Confusion may be your only indicator because all of a sudden your patient can go from knowing who they are to being completely confused. This is why I say what we talked about in chapter 4 was knowing the difference between delirium, dementia, depression, and confusion. You want to know what your different confusions mean so that way you can better take care of your patient. Assess motor function, sensory perception, cognition, communication ability, dysphagia, aphasia, any sort of numbness, paralysis, cognitive abilities, endurance level, and range of motion. So with this, you want to see how much your patient can do. In Once again, I know I keep on saying can't stress this enough, but it's very important that you use the equipment appropriately and remember your body mechanics. Like, there's a nursing shortage, and with that nursing shortage means that we've created a lot more machines that you can use. It's important that you actually use these machines. Because if you don't use them, then what's the point of them? So remember your equipment and body mechanics save your back. Don't just go in there and try to quickly pull because you can end up hurting yourself really, really bad. So just make sure that you're using appropriate measures to keep yourself safe and keep your patient safe. So before you move anybody, just make sure that you know what to do. Skin and tissue integrity. Assess other conditions that may impact skin integrity. Are they incontinent? How can that impact skin integrity? Well, if they're incontinent and no one's changing them, then that can make that a very moist environment. Do they have diabetes mellitus? If they're diabetic, then that makes it much more harder for them to deal with a skin pressure ulcer and possible causes. Depth of the pressure ulcer, colitis, how much tissue damage they have, baseline and ongoing assessment. So once again, my main thing is this ongoing assessment. Is it getting better or is it getting worse? You always want to accurately document how it's going. It's okay if it has gotten worse. We just need to know it's gotten worse because we need to know, is it because nobody's changing the patient's bandage, or is it because there's some sort of underlying disease process that's going on? You want accurate assessment data. Assessment of functional ability to perform ADLs. So how are they able to perform their activity of daily living? Watch for medications. Like I said, are they on a loop diuretic that's going to drop their blood pressure? If they're on a loop diuretic that drops their blood pressure, what is the safety issue there? Risk of falls. I forgot to do the Dora the Explorer thing, but you get it. You just want to watch for anything that's going to make them unsafe. And make sure you collaborate with your team members. Like, what's it called? If you know that you just gave them a blood pressure medication that's going to drop their blood pressure, let them know that you want to move that client from lying to standing very slowly. You don't want to just jump them because it could drop their blood pressure. Use what you learned in pharmacology and apply it to these med surg topics. Psychosocial assessment, body image and self-esteem. Like I said, a lot of patients, well, not a lot of patients, but you'll have some patients that went from independent to now dependent. You need to understand that that can have a big toll on their self-esteem. Use of defense mechanisms. Sometimes these patients may not talk to you the way you want to be talked to, but it's because it's their way of defending themselves. You need to have a very upfront kind of conversation about it. Response to loss. Some of these patients are completely isolated by themselves. Pressure of stress-related physical problems. Some of them are in constant pain. Fatigue, appetite changes, powerlessness. So you want to see how is all of this affecting how they perceive themselves. Because if they're not in the best mindset to get better, they just won't get better. So you need to assess, hey, what is going on? Never ask, why are you feeling this way? If you ask why, that implies that they did something wrong. So just kind of use your therapeutic communication with them. Culture and spiritual considerations, availability of support systems for the patient. What are their spiritual considerations? Do they believe in God? Do they not believe in God? Do they need somebody to come in to talk to them? Do they not want to talk to anyone? Ask patients what is important to them, what gives meaning to their life. Now, what gives meaning to their life is different for everyone. For some people, it may be their family. For some people, it might be their dog. For some people, it might be a game they really like. Whatever it is, you want to know what that meaning is, and you want to have empathy for if that's what gives them meaning to life, then you want to do what you can to help support that. Cultural, spiritual, and religious needs. You don't have to have the same culture or spirituality as your patient, but you do need to respect it. You need to be emotionally intelligent enough to understand that while I may not agree with what this patient has going on, I can still take care of them in an unbiased manner. Sexuality and intimacy needs. Once again, it's very similar to that cultural, spiritual, religious needs. You just need to be open-minded of what is it that they consider intimate? What is it that they don't consider intimate? And not everybody's the same. Some people may be very intimate, some people may not be very intimate. Vocational assessment, collaborate with vocational counselors. Basically, sorry. I apologize. I thought somebody was coming to my room again. So vocational assessment is basically what are we going to do to get them back into society? Like, what kind of jobs are we going to get them? What are their vocations afterwards? Can we get them in line with working at a fast food restaurant? Can we get them in line with going to work for wherever it is we want to get them to work at once they get out of this rehabilitation center? Analyze the cues and prioritize hypothesis. So priority collaborative problems. So these are problems that are associated with everyone. Decreased mobility. I've assessed my patient. I know that they have decreased mobility. So now I need to figure out what should I do about this decreased mobility. Maybe put something like falls risk. Maybe encourage them to use their call light. Those kinds of things that I know they have decreased mobility. So now I need to converse with everybody to see what I can do for them. Decreased functional ability. Maybe I know that it's going to take them longer to take their pills. So now I need to kind of put that in the back of my mind when I'm scheduling out how I need to take care of the day. Risk for pressure injury, making sure that we're turning them, making sure that they're moving. Urinary incontinence or retention, and changes in bowel function. So once again, I've assessed, I see that these are the problems. Now with this information, I need to start hypothesizing of what I need to do to fix each of these problems. So once again, increasing mobility, coordinate care with physical therapy, occupational therapy. If you know that your patient struggles to walk, maybe I'm going to go ahead and go with physical therapy so I can see the best idea of what to do next. Assistant positioning and transferring. Once again, this is where I'm talking about when you collaborate with physical therapy. If I know I just gave them a blood pressure medicine, then I want to say, hey, physical therapy, you may want to be a little bit slower or careful when you move them from lying down to standing up. Because when we move them from lying down to standing up, what's going to happen to their blood pressure? Go all the way down. Assess level of assistance needed. Are they able to do things independently? And be aware of this assessed level of assistance needed. Patients, it really depends on how much energy they have. Sometimes they may be fully able to take care of themselves in these rehab centers when they have enough energy to do so. So kind of work with your patient as well to see, okay, when do you start getting tired? When do you start needing more help? Using standardized tools, that's where we kind of used those tools that we talked about in chapter 4 is, are they a falls risk? Safe patient handling and mobility. So, like I said, all of this comes back to what assistive devices are they using and how can I promote activity without putting my patient into danger? So, increasing mobility, identifying triggers for patients with cognitive impairment. So, what do we mean by triggers for patients with cognitive impairment? So, triggers for cognitive impairment can have a lot of different forms. It can be something like maybe this patient has PTSD and something that triggers them is loud noise, which when they hear that loud noise, it puts them in a different mindset and it makes it so they're at a higher falls risk or they're a danger to themselves or others. So you just want to know what are these triggers for this patient and how can I help prevent it from getting worse? Monitoring their weight, watching their gait training and range of motion exercises, all things to try to increase their ability to be flexible, increase their ability to have better functions. Increasing functional ability, collaborating with your occupational therapist. Restorative nursing programs. So one of the things that they have is this, what is it called? I drew a blank. But like sometimes after a patient has had an MI, like a myocardial infarction, which is a heart attack, what they'll do is they'll put them on a regimen where they just have to basically come to this like gym type area and they go to that gym area and somebody basically watches them on a treadmill to see how they personally react to how their heart reacts to being on this treadmill. Assisted devices, adaptive devices, make sure you encourage your patients to use their assisted devices. A lot of them will just be like, nah, I don't want to use it. Encourage it. Because the safer they are, the less likely they are to lose more functions. Preventing pressure injury, frequent position changes. If you can get up and walk, let's do it. Sufficient nutrition intake, adequate skincare, use of pressure relieving or pressure reducing devices. These devices help somewhat, like they will help the patient, but the thing that helps them the most is honestly getting them off just laying in one position. You want to have that frequent turning. Here are some things about establishing urinary continence. Um, Overactive spastic bladder is incontinence with sudden voiding. Underactive flaccid bladder, urinary retention or overflow. So things that we can do are things like bladder scanning them, seeing how much do they actually have within their bladder, and using intermittent catheterization. The reason we don't just put a Foley in them is that can cause them to end up developing a UTI. So we want to do things that are temporary, not like something that's going to stay there too long. Something else that kind of helps with them is consistent toileting schedule. So if you kind of put them on the mindset of this is when they're going to go, they can start redeveloping. It's kind of like if you've ever had to teach a toddler how to use the bathroom. It's similar in the sense of we're trying to retrain you how to appropriately use the restroom. Um, Drug therapy, once again, with this, the physician might end up scheduling them to be on a diuretic in hopes that maybe that'll cause them to pee out some of that fluid, or they might put them on some other types of medications. Like if they've got an enlarged prostate, they might put them on a medication to help with that. So, yeah. Establishing bowel continence. What I will say about this is, once again, you want to go with the least invasive thing you can do. A lot of times you want to just walk your patient. You want to give them things like fiber, like a high fiber diet. You want to do things like increasing their fruit intake before we start jumping into things like giving them a laxative. A lot of older adults will really rely on laxatives, but it doesn't help because then it makes it harder for them later. What I will say is you want to look out for people who are dealing with something like they're an older adult and they're just incontinent, or they may not be able to control their bowel, versus somebody who may have a lower motor neuron disease. So these like flaccid bowels are a little bit different. With them, depending on the spinal injury they have, things can become a little bit more difficult for them to control their bowel because basically depending on where they got hit in the spinal injury, what it can cause is a disconnect between the neurons going towards the upper half with the neurons going to the lower half. And that's something we'll talk about later in MedSurg 3. But the point of it is just assess your patient and see what can you do that's the least invasive before we get into the more extreme things. That's that bowel retraining that we're talking about. And this is just kind of like a chart from your book with the reflex spastic neurodisability versus the flaccid. So lower motor neuron spinal injuries below T12, usually absent stools for patients with complete lesions. Defecation without warning may not empty completely for reflex. So rehab, care, and coordination and transition management begins at admission. So just like in the hospital, discharge begins very first day you come in. Home care preparations. So a lot of times before they can go home, we have to see, is their home safe? So that's when you would collaborate with case management, with your social worker to say, can they financially take care of themselves? Self-management education, OT, PT, teaches ADLs, so making sure that they know it. Nurse reinforces the education, refer to mental health professionals as needed. Healthcare resources assess their needs. Do they need someone else to come in and talk to them? Coordinate with a case manager and healthcare provider. And then finally, you want to look at your evaluation. So you want to see how's their mobility, how's their self-care? Do they have intact skin? Have they established urinary elimination? Do they have regular stool evacuation? So just kind of looking and seeing what's my patient at. Um, like I said, just be very honest with your outcomes. If your patient did not get better, that's okay. We just need to know they didn't get better so we can go back to the beginning and change our plan of care. That's the whole point of this, is we assess, we hypothesize, we experiment, and then we see if that experiment worked. It's the science of nursing. The art of nursing is kind of that therapeutic communication, but the science very much is following A, B, C, D, and E, see if it works. Didn't work, go back to the beginning. So kind of try to see it that way when you're studying is, okay, what's my assessment? What am I going to do about this assessment? What do I think will work? I'm going to initiate this, and then I'm going to see, did it work? And if it didn't work, I go all the way back to the beginning. But that should be everything. If you all have questions, please let me know. Thank you.